Thank you for tuning into today's webinar hosted by the STEEP Superfund Research Program. Our webinar series, which focuses on PFAS on Cape Cod, is called Connecting Communities with Science for Solutions. I'm Laurel Schaider. I'm a senior scientist at Silent Spring Institute, and I co-lead the Community Engagement Core for STEEP. I'll be moderating today's session. STEEP stands for Sources, Transport, Exposure, and Effects of PFAS. We are funded by the National Institute of Environmental Health Sciences. STEEP is led by the University of Rhode Island with researchers from Harvard University and Silent Spring Institute. The goals for our webinar series are to share findings from STEEP research with members of the Cape Cod community and broader audiences, to elevate the voices of community leaders on Cape Cod who are working to address the many challenges of PFAS, and to share examples from Cape Cod of how researchers and communities can work together to find solutions. I'll start with a few housekeeping items. So our speakers will both take questions at the end. And if you have any questions, you can feel free to type them into the Q&A at the bottom of your screen, not the chat, but the Q&A. The audience will be muted the whole time. So if you have your question to ask, please put it into the chat. We'll do our best at the end to get through as many questions as possible. Based on our past webinars, we may not have time to get to everyone's questions. I'm very excited for today's webinar focused on PFAS health effects and clinical perspectives. We have two great presenters today, Dr. Angie Slitt, professor in the College of Pharmacy at the University of Rhode Island. Angie leads one of the research projects within STEEP. And as a non-toxicologist, it's been great to learn from Angie over the past almost 10 years of our STEEP team about PFAS toxicology. Our second speaker will be Dr. Jill Oxley, a breast surgeon at Cape Cod Healthcare, and she's also a board member for the Massachusetts Breast Cancer Coalition. And the Mass Breast Cancer Coalition is one of the core community partners for our community engagement work on Cape Cod. Angie and Jill will both be talking about a family of chemicals called PFAS. If you're here today, you likely have already heard something about these chemicals. If you're new to PFAS or would like a refresher, I'd recommend that you look at the STEEP website and check out some of our previous webinars to provide more foundational information about PFAS. So with that said, I will now introduce our first speaker, Dr. Angie Slitt. Dr. Slitt is a professor in the University of Rhode Island College of Pharmacy and a lead researcher in the STEEP program. A toxicologist with more than 20 years of experience, her work focuses on how PFAS and other environmental contaminants affect liver function, metabolism, and related health outcomes, including non-alcoholic fatty liver disease and metabolic disorders. Her research integrates laboratory and epidemiological approaches, and she is actively engaged in scientific leadership through editorial roles and professional societies. She's a dedicated educator, mentoring students all the way from high school to graduate school as part of her work at URI. Thank you so much for joining us today, Angie.
Thank you, Laurel, and thank you for inviting me to give this webinar. I'm very excited to present to you today. Okay. All right, so today we're going to talk about our project within the STEEP Superfund Center with regard to PFASs and human health effects, and specifically to some of the findings that we have with human liver, and then also talk more broadly about clinical interventions for PFAS exposure. So I just want to take a moment to remind you, I know everyone in this audience is often very familiar with PFAS, but just as a quick introduction. So we have different ways in which PFAS as a chemicals we can be exposed, such as water, air, soil and vegetation, consumer products, and occupational exposure. Of course, there among Cape Cod, there's been a concern with regard to water contamination. And so we do appreciate that drinking water often is a very common source of exposure for humans. So PFAS have a variety of adverse health effects that they're associated with. For example, they're associated with changes to the immune system, higher cholesterol, There are some relationships with kidney disorders and kidney cancer. And today I'm going to talk to you about changes in liver enzymes, and in particular, our findings with PFAS with regard to accumulation in human liver. So what do PFAS do to the liver? So first of all, we know that whether it's humans, rodents, animals in the wild, birds, that the liver accumulates PFAS. And often the liver, and this is important because the liver controls distribution of toxic chemicals throughout the body. And it is a major site for accumulation for PFAS, at least the legacy PFAS that you have often heard about, such as PFAS and PFOA. And we'll dive deeper today about other emerging PFAS. PFAS in humans, as well as rodents and preclinical species such as monkeys, PFAS can be associated with elevation of markers of liver damage. And again, this has been shown through many, many studies and in human studies, such that PFAS tend to be associated with slight elevations in markers of liver cell injury, such as here we're showing. We do know that in rodents, this doesn't happen in humans, but that rodents, there can be an increase in liver size and liver cancer that are associated with PFAS exposure. This doesn't appear to be the case for humans, but we do know that this is a phenomena that happens in rodents. And then there are multiple studies now that have associated PFAS exposure, at least some PFAS, with the association of fatty liver disease in humans. And this is MASLD, metabolic associated steatotic liver disease, is associated with an accumulation of fat in the liver that then can eventually or potentially progress on to a more serious form of liver disease, and is associated with increased cardiovascular risk. So as researchers for the STEEP Superfund Center, there's questions we really want to ask. Some of them being, for example, what PFAS do we find in human livers? Are we finding the same PFAS that we see and observe in human serum samples? Are there other PFAS? Does liver potentially store PFAS? Second of all, if PFAS is reduced, does that also lead to lower PFAS levels in liver? So if an individual is undergoing an intervention, or if over time we're withdrawing certain PFAS, do tissues in the body also reflect that reduced exposure, or is it just being cleared from the blood? And last, are PFAS levels in liver associated with liver disease? So these are the questions that for one of the projects in our laboratory, the STEEP Superfund Center has helped us be able to address and work on. So moving into our study, I'm a toxicologist by training, and we do everything from cell-based assays all the way to working with humans. And one of the questions that we had was, when we move from rodent models, how can we really learn and understand more about human exposure? And so what we decided to do was to kind of go to tissue banks across the country in which we knew they were collecting human liver samples, and kind of collecting other data about those samples, and understand what PFAS exposure looks like across in livers collected from humans across the country, and how does that exposure change over time as well. So, for example, we chose the year 2000 because that's when certain PFAS started to be voluntarily withdrawn from use. And we went ahead and so just to understand too, these were donor livers. These are collected with consent. These were often livers that were being either removed from a patient because that patient was undergoing transplant, or it was a healthy liver and part of that liver was maybe being resected or not used. And so that tissue was then donated for research use. So overall, we collected about 200 human liver specimens collected across the country. These largely came from the Midwest, New Jersey, but other sites across the country as well. We then go ahead and take those tissues and bring them back to the lab and under safe conditions, extract PFAS from them using certain solvents and chemistry in the laboratory. And then through the Steep Superfund Center, used a technique called mass spectrometry to basically chemically detect and quantify up to 53 different PFAS in those human livers. So we measured 53 legacy and emerging PFAS in livers, and I'm going to walk you through some of the data that we were able to generate. So first, when we look at some of the common PFAS that you might have heard of, might know about, the legacy PFAS, we saw that of these livers, basically 99% of them all had linear chain PFAS and 95% had branched chain. So pretty much every liver that we came upon had PFAS in it. Many of those livers also had PFOA as well as PFHXS. And just to kind of guide you, these are PFAS is found in many products. These are often components of AFFF. PFOA can be found through other sources such as drinking water. Also to kind of orient you, this is a log scale graph. So this is upwards of 1,000 nanograms per gram PFAS. This is scale of 1. So this is a bit of a compressed kind of representation. So these are generally the highest. PFAS was the most prevalent and the most high. So then we moved on and looked at other long chain PFAS, and we see that in these human liver samples, that again, a large number of them have these long chain PFAS, such as PFNA, PFDA, PFUDA, PFDOTA, PFTRDA, as well as 673 FTCA. And then we also found many precursors in our liver samples. So these are all different precursor type of PFAS, and these were also observed in high frequency in our human liver samples. Interestingly, for example, 8,2-FTS was very abundant in the liver samples. So when we look across this scale, I just want to draw this to you for a few things. So first of all, this is in nanograms per gram. So again, pointing out that PFAS was the highest, but really noting that basically all of the samples we encountered from the humans banked over the past 20 years had some type of PFAS in them. And I don't have time to show you today, but of this subset, we then went back and looked at the bloods that were matched to these liver samples. And there were many in which we saw the PFAS in the livers, but not in blood. So liver definitely is a site for storage. Our concerns from the Steep Superfund Center is that there are many other emerging PFAS that we are now detecting. So to continue on, when we look at these trends over time, we can kind of break PFAS down into different types. So again, we can see that early on in the 2000s, our sulfonic acids like PFAS were generally driving most of the concentrations in those human livers. And then over time, the total concentration gets lower, and we start to see this breakdown within the profile that other PFAS are emerging. So first of all, I just want you to note that these bars represent the total amount. So the total amount is clearly declining over time. So that tells us as we reduce PFAS kind of usage like across the globe, or that the levels do decline. However, one thing we need to think about is that even though those levels are changing, what we see is as we go from 2000 to 2004, the types of PFAS that we're seeing in those livers, the profile and abundance, that pie chart shifts, if you will. And so we're starting to see more precursors and novel PFAS being present in those livers compared to, say, mostly PFAS and PFOA. So that's our concern. So next, I just want to talk to you a little bit about things we can do to disrupt PFAS exposure. I just want to make sure I'm doing okay on time. So we think about PFAS being taken in, and then the question really is, how are PFAS absorbed? They're absorbed in the gut through transporters. Then they get from the gut into the bloodstream where they can bind to certain proteins in the blood called albumin. They then get distributed. They don't get metabolized, so they're not getting cleared by the liver, and they often stay in the liver, and a small amount get excreted. And the concern and the reason why they have long half-lives is because they undergo this kind of constant cycling. You take them in, they bind to proteins, they get to liver, they don't get broken down. A small amount gets excreted into feces, and then a large amount get reabsorbed back through the intestine, and they stay in this cycle. And so we're interested in understanding what we can do to mitigate exposure. And our questions are, can we decrease PFAS absorption? And then also, can we enhance PFAS elimination? And I want to kind of switch gears and bring you back to that concept. So the National Academies of Science has a committee that has met and proposed guidance about levels of PFAS and what should be done. And I just want to point this out to you. There's guidance on this. This is publicly available. And this is really an additive sum of a particular 7 PFAS. And basically, if you meet greater than 20 nanograms per mil of PFAS, then there are kind of recommended guidances about how to intervene. So I just want to draw this guidance to you. You can look it up. If you have questions, you can email me or Dr. Schaider. And so when we think about ways to reduce burden, currently there's 2 ways that are not maybe medically recommended, but under exploration. And one is through serial phlebotomy. There's evidence that with serial phlebotomy and blood draws, you can lower PFAS effectively. The second is through a drug called cholestyramine. And cholestyramine is able to, it doesn't get really absorbed, it hangs out in your intestines, and it can bind to the PFAS, and then you eliminate PFAS through fecal excretion. So these are kind of the 2 current ways in which people are exploring lowering serum PFAS. And this is just an example of one study that was published showing exactly that. And so individuals were given cholestyramine for 12 weeks, and they were able to see a reduction in PFAS by 60%, PFHXS, PFOA, PFNA, and PFDA. So this is a percent decrease, showing a 60% decrease, 20% decrease, about 20%, 40, and 50% decrease over this 12 weeks of therapy. So for our Superfund Center, we are going to try something very similar, in which we're testing the drug Welchol. It's colesevelam. It is similar to cholestyramine, except it has the capacity to bind more bile acids, and because of that, we think that it will bind more PFAS. We are proposing to reduce the dose by 50%. It can come in a pill versus powder. It is approved for adolescent use, and it also lowers HbA1c and has an anti-diabetes effect. So with that, I just want to take you through what we are funded to do in 2026, which is to evaluate colesevelam, aka Welchol, as a PFAS lowering agent. We are doing this out of the VA in Maine, so VA Togus, as well as Robley Rex in Kentucky. And we're recruiting veterans who maybe had PFAS exposure during military status. Now we're checking them first to see whether or not their PFAS are greater than 20 nanograms per mil. And if so, they'll be invited to participate in a placebo-controlled study in which we'll be testing Welchol as an intervention to lower PFAS. So if there are any veterans in the area or on this webinar, or you know someone who might be interested in participating, I have my contact information at the end. Our goal here, again, is to lower PFAS because colesevelam, aka Welchol, can bind to PFAS, and we theorize that it will enhance the excretion of PFAS fecally, and you will lower serum PFAS. So with that, I just want to make sure I'm on time and not going over. I want to acknowledge the many collaborators that we have. We have the Steep Superfund Center, my laboratory, Dr. Schaider, Dr. Sunderland, Lohman, Bekanova, Diamond, Neville, Amber Neville for all of their help within the Steep Superfund Center. We have many clinical collaborators who are working with on this project. And again, if you are a veteran and you're interested in participating in our clinical trial, you can contact me. We will be starting recruiting, we anticipate, in about April. And with that, thank you, and thank you to Silent Spring for hosting the webinar today.
Wonderful. Thank you so much, Angie, for that really informative discussion. I'm sure we'll have a lot of questions based on that. But for now, we'll be listening to our second speaker. I'm really pleased to have Dr. Jill Oxley. Jill is a breast surgeon who has practiced on Cape Cod for over 20 years. She serves as Director of Breast Care Services at Cape Cod Healthcare and as a member of the Board of Directors for the Massachusetts Breast Cancer Coalition and the Cape Wellness Collaborative. Also a breast cancer survivor, her clinical work focuses on breast cancer as well as benign breast disease, high-risk screening and risk assessment, along with multidisciplinary approaches to cancer treatment, informed by decades of caring for patients in the region. And Jill, I'm so glad to have you here as part of today's discussion.
Thank you. And good afternoon, everyone. Thank you for the opportunity to participate in this very important webinar. Now, we are going to shift gears a little bit and talk about these potential implications on breast health. Again, my name is Dr. Jill Oxley. I'm a breast surgeon at Cape Cod Hospital and the Director of Breast Services for Cape Cod Healthcare. My interest in women's health started in college during my pre-med shadowing experiences. And then my interest in breast cancer truly began in medical school, where I did research with my mentor, surgical oncologist, on axillary lymph nodes and breast cancer, a topic as relevant today as it was in the 1990s. After completing my residency in general surgery, I performed both general and breast surgery until my own breast cancer diagnosis 9 years ago spurred me to make the change and devote the entirety of my practice to breast care, which I've been fortunate to do for the last 7 years. In 2018, an amazing woman named Cheryl Osno reached out to me about joining the board of directors of the Massachusetts Breast Cancer Coalition, where she serves as an executive director. Just reading the mission statement that MBCC, quote, is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy, couldn't say no. There is so much we don't know about the causes of breast and other cancers, and so much more to be learned than they can teach us in medical school. As we all know, 1 in 8 women will be diagnosed with breast cancer in her lifetime. Genetic mutations associated with an increased risk of developing breast cancer still account for only 5 to 10% of all breast cancers diagnosed in the U.S. Only 15% of women diagnosed with breast cancer have a family history of breast cancer, and 75% of women who are diagnosed with breast cancer are considered average risk. For the 25% of women who are considered high risk, in addition to genetic and familial risk, we can factor in personal history of breast biopsies that showed high-risk lesions, along with other personal, gynecologic, and reproductive factors associated with increased breast cancer risk, such as having a high body mass index, early onset of menstruation, late age of menopause, nulliparity or older age of first-term pregnancy, and use of combination hormone replacement therapy. But these calculators are still limited and potentially inaccurate in women of color. Black women are more likely to die from breast cancer than women of any other racial or ethnic group, even as breast cancer death rates have declined in every racial and ethnic group since the 1990s. Death rates in American Indian and Alaskan Native women have remained constant. And while Black women have a 5% lower breast cancer incidence than white women, they have a 38% higher risk of dying from the disease. This suggests not only differences in tumor biology, but potentially in social determinants of health. And when a woman is identified as being at high risk of developing breast cancer, we can institute high-risk screening, supplementing annual mammography with screening breast MRI exams. But 16% of breast cancers are diagnosed in women younger than age 50, and only last year did all major organizations recommend starting screening mammograms for women at average risk of age 40. And more intensive screening doesn't decrease a woman's risk of developing breast cancer, it just hopefully lets us detect it earlier. So there are two questions that I am asked nearly every day. Women who have been diagnosed with breast cancer want to know why, and women who are at high risk of developing breast cancer want to know what they can do to decrease their risks. For both groups, I recommend attaining or maintaining a healthy body weight, getting regular exercise, eating a diet high in fruits and vegetables or plant-based, not smoking, and limiting alcohol. Then there are the more specific concerns. Someone might say, I have a close group of 6 friends and now 5 of us have been diagnosed with breast cancer. What's going on? Another might say, I live on a street where 8 people have been diagnosed with cancer over the years. They ask if it's the water, the power lines, the military base, or something else. That's why research into environmental causes of breast cancer is so important. Social determinants of health are deeply intertwined with the environment and environmental justice. Here on Cape Cod, Hyannis has a lower median household income when compared to other towns, and nearly twice as many foreign-born persons than the Cape as a whole. As a board member for the Massachusetts Breast Cancer Coalition, I see firsthand how proud MBCC is to be a community partner for the Slitt Community Engagement Corps. PFAS chemicals have been linked to a wide range of health effects, including immune system toxicity, elevated cholesterol, altered mammary gland development, effects on the thyroid, and as we just saw, the liver, and cancer. Scientists are concerned that exposure to these chemicals that alter mammary gland development may increase the risk of breast cancer later in life. As we also saw on Dr. Slitt's slide, however, we don't have any guidelines for changing breast cancer screening when patients are found to have these higher PFAS levels. The patients who ask these questions are usually aware of PFAS or these forever chemicals. Sources of PFAS have been identified as fire training areas, airports, military bases, landfills, municipal wastewater biosolids, along with private septic systems. And some of the highest levels were detected in the Hyannis water system. And while this is one of the smaller community water systems, it does serve many lower income and immigrant families. But fortunately, the Hyannis water system invested millions of dollars in water treatment to remove PFAS. And levels of PFAS and PFOA in Hyannis tap water are now below the U.S. Environmental Protection Agency's 2016 health advisory, 70 parts per trillion combined. However, there are many areas of the Cape where the water comes from private wells, and private well owners are not required to test for PFAS. But Slitt's Community Engagement Corps tested water samples from 101 private wells in 12 towns across Cape Cod. They reported key findings in 2021. 46% of wells had detectable levels of at least one PFAS chemical, 28% had 2 or more. The percentage of wells with detectable levels of at least one PFAS chemical varied across different parts of the Cape, with the highest percentage in the Mid-Cape and the lowest percentage in the Lower Cape. Wells with higher levels of nitrate had higher PFAS concentrations, and since nitrate is an indicator of septic system impact, this does suggest that septic systems could be a source of PFAS in private wells. But fortunately, none of the wells exceeded the federal health guidelines for PFAS, and only 3% exceeded a drinking water standard adopted by Massachusetts in 2020. But lowering the PFAS in the water does not decrease the exposures that have already occurred. It is important to not only limit exposure moving forward, but to understand what risks may already be in place due to prior exposure. For example, Silent Spring Institute issued an important news bulletin in November of 2024 regarding breast cancer and plastics. They noted that breast cancer is the most common cancer worldwide. Recent data show incidence rates for many cancers have been going up in people under age 50, and most of these early onset diagnoses are breast cancer. Because well-studied risk factors such as having fewer children cannot fully explain this trend, they noted that researchers have turned to chemicals in food, water, and consumer products as likely factors. Earlier in 2024, scientists at Silent Spring Institute identified more than 900 chemicals that could increase breast cancer risk based on their ability to cause mammary tumors in animals, damage DNA, or interfere with estrogen and progesterone. The vast majority of breast cancers are hormone receptor positive or hormone sensitive, as evidenced in these personal reproductive factors I mentioned earlier, and we've just heard about PFAS in the liver. The liver is intimately involved in the metabolism of estrogen. Then in 2025, Silent Spring Institute published preliminary results from the PFAS multi-site study, which included adults and children who lived in Hyannis between May 2006 and July 2016, among others. They found 4 PFAS compounds in the blood of almost every person in the study. However, levels varied between sites. Both adults and children had higher levels than the general population. Children had lower levels than adults. And interestingly, premenopausal females had lower levels than males, but in the older adults, the levels were similar between men and women. Next steps include analysis of these results to understand how exposures to PFAS may affect the health of adults and children, and estimating past exposures from historical drinking water contamination. So what can I tell my patients? And how can I explain my own breast cancer diagnosis as one of many women diagnosed before age 50 with no family history or genetic mutation? For the majority of women, myself included, we don't know the why, but I let them know that there are researchers hard at work to answer these questions. I advise my patients to limit exposure to highly processed foods, in addition to the other healthy behavior and lifestyle choices mentioned before. And I can direct both patients and my colleagues to websites such as STEEP, Massachusetts Breast Cancer Coalition, and Silent Spring Institute for more information and education. It is imperative to bridge the gap between researchers, clinicians, and the general public, which is why I'm grateful for the opportunity to participate in today's webinar. Thank you for your attention.
Wonderful. Thank you so much for sharing your thoughts and perspectives, Jill. That was really a great overview, and thanks for sharing your personal experiences as well. So now we are going to transition into the Q&A portion of our session today, and I'm going to kick things off with a couple of questions for you, Angie. First question, and for the audience, please feel free to type questions into the Q&A, and we'll get to them as we can. So Angie, levels of long-chain PFAS in the blood of people in the US have declined since the early 2000s. And as we could see your results, same thing for livers as well. Industry has phased out the production of long-chain PFAS in the US and replaced them with short-chain PFAS and other chemical relatives, such as perfluoroethers. These newer PFAS don't accumulate in blood to the same degree as the long-chain PFAS. And it seemed like from your liver results that you weren't seeing as much accumulation of those newer PFAS as well. So I guess a couple questions. Do you think that these emerging PFAS are accumulating in a different part of our body other than the liver?
Yeah, so to answer that question, I mean, it's certainly possible. So as we change the chemistry, it doesn't always mean that the PFAS will still distribute to the liver. As they get shorter and smaller molecular weight, they are more likely to shift to kidney and undergo urinary excretion, depending on the type of chemistry. So if they become more neutral, then they're more likely to be kind of permeable in the body, and that means that they can shift to other types of tissues, such as fat tissue, or more, they can kind of distribute in a different way. So the answer is kind of, it's a bit of a whack-a-mole as the chemistry changes, how the molecules behave change also. What I would also say is a couple to add to that. It's very preliminary data, so I have to be very careful, but there's some evidence that we are seeing some shorter chain PFAS in some liver tissues too. So what we don't really know is this a matter of exposure versus persistence? It's hard to disentangle that. In general, the sentiment is maybe that the shorter chain molecules are not as bioaccumulative. Our data tend to support that. But then what I would also say is, just because something enters and leaves the body doesn't mean it can't have a pharmacological or toxicological effect too. I think we have lots of examples of short half-life molecules that can still have pharmacological effects.
Yeah, I think that's super important. It kind of leads into the next question I also wanted to ask you. Just because chemicals don't accumulate in our bodies for a long time, it doesn't mean that they're not harmful. We have quite a lot of information about toxicity of long-chain PFAS. I'd say from your perspective and expertise, what would you say is the current state of knowledge on the toxicity of the short-chain and emerging PFAS, and how is your research addressing some of the knowledge gaps in this area?
Sure. So what I would say is we have a sliver of knowledge for those short chain and emerging PFAS compared to our legacy long chain PFAS. As someone who's coming off a cold, if you can't tell, I've been taking ibuprofen and acetaminophen, a lot of it, and those are just examples of they clearly have pharmacological effects. Yeah, acetaminophen is cleared from the body in 2 days. So I just want to bring up the notion that a pharmacological effect versus persistence isn't always one to one. But of course, we, care about something that can be persistent in the body for a very long time. Um, how we're trying to address it, I think we're trying to do our best to understand exposure. So, really heavily profiling human participants, obviously willing human participants to understand in 2025 what are the exposures, using that, trying to use the best methodology possible, and then correlating them with disease. So, for us, we still do lots of rodent studies. We do cell-based studies, try to do our best working with collaborators. I know some of them are on the call today, like Uday Apte in Kansas and Fabian Fischer, who's also part of STEEP, to understand toxicological effects and then bridge that to humans.
Great, thanks for that answer. Yeah, I think about that a lot with chemicals like BPA also that we're
Sure.
concerned about in terms of their toxicity, which is also very rapidly screened from the body. So sticking with the theme of kind of emerging PFAS, this was a question that came in from someone who, when they registered for the webinar about TFA. So by way of background, recent testing has shown that TFA, which is an ultra short chain PFAS, is present throughout our environment, often at much higher concentrations than other PFAS that we're used to thinking about. It's got some different types of sources and maybe some differences in the chemistry, but the question that came in is TFA toxic? And if yes, what are the specific toxicities of PFAS to humans in the environment?
Yeah, so I don't think we know a lot about TFA in general. I'm, it's there's so much to do. And so I have to say what really we're starting to pick up a signal for TFA in our liver samples, which we want to confirm and double check and are probably triple and quadruple checking that. And really, what I would say is this is why it's important to get federal funding and to fund science because it allows us to use different models, such as cell-based models, rodent models, and then go into exposure studies and understand causal effects and associations. But I have to say we don't know very much about those and their toxicological effects.
Mm-hmm. Okay, thanks for that. And yeah, I think a cautionary tale for when we create really persistent chemicals and put them out into the world without fully studying them. It's a huge problem, and I'd like to think we could learn and not repeat the same mistake in the future.
Yeah.
Did you want to add to that?
No, go ahead.
All right, Jill, I had a couple questions for you. So public health researchers study effects at a population level, whereas clinicians like you are, interacting with individuals who have questions about their own health. How can public health researchers communicate about what's known about PFAS health effects? I know you're familiar with PFAS as part of Massachusetts Breast Cancer Coalition and from all the attention that PFAS have received on Cape Cod. And for public health researchers who are wanting to kind of bridge that gap, are there certain formats or venues that can be effective to share information as clinicians are trying to get up to speed about PFAS?
I think one of the most effective venues are webinars just like this, combining the researchers with clinicians is a good way to get the word out, and sending news bulletins, people who subscribe to Silent Spring, STEEP, NBCC, that's an excellent way to get the word out to the general public. And I'll admit sometimes patients ask me a question and I say, I don't know, I'll have to go look it up. So there's a lot of information out there, and webinars are a great way to share that information.
Okay, that's great to know. This is a good format. And when you, as a clinician, when you go look something up in response to a patient's question, like where are your top places to go to learn about these kinds of issues?
But for these PFAS issues and what I just mentioned, it's always good. I tell patients that I make every effort myself not to ask Dr. Google. who has questionable certifications, but going to reliable websites where people are publishing in peer-reviewed journals, real studies, give us real data, and that's really where change can be made.
Okay. Great, thanks for that. Another question for you, Jill. What do you think other clinicians in Hyannis or other PFAS impacted communities should know about PFAS, and how would you recommend that they incorporate PFAS into their clinical practice?
So I know some of our local pediatricians were involved in the blood study. It's important to know that the water is safe. It's important to know that yes, these chemicals exist, but we still don't know to what level anything needs to be treated. And so the more research continues, and we'll find out, is there a level at which someone should start having phlebotomy or consider taking these drugs? Or maybe it's not a question of lowering blood levels, but do we have screening guidelines, such as on that chart that was shown earlier? We don't have any changes in the screening for breast cancer. It's still based on the other clinical factors, but that could change if we decide that at some point there is enough data that PFAS exposure should lead to earlier screening, in addition to all these other clinical factors.
Okay, great. Thank you for that. Angie, going to turn it back over to you. Following on the kind of the questions about PFAS and health effects, one question that came in is whether there's any connection that's been identified between PFAS and MASH or fatty liver disease.
Yeah, so there was a study probably maybe about 2 years ago, year and a half ago, where they did something called a meta-analysis, where you kind of evaluate all of the literature to date, whether anything from human studies to rodent studies, cell-based studies, and kind of put all that data together and kind of like statistically analyze those studies and determine whether or not there's some sort of strong association. And so in that body of work, they did find a strong association between certain PFAS and mast cell D. What I can tell you is that there are other ongoing studies that are being worked, kind of either are being worked on, say through the University of Southern California, in their SHARP Center, where they're looking at associations with mast cell D in adolescents. And then in particular for my research group and Steep Superfund Center, we do have a 1,000 veteran study in which we're looking at fiber scans from veterans and associating that with serum PFAS levels, and also looking at how their fiber scan, how these liver disease measurements change over time, over the course of about a year and a half. So there does appear to be associations in rodents. It does look like there are some associations between PFAS administration and inducing fat accumulation in liver. It's a little confusing. Rodents are a little bit different than humans, but there seem to be these associations. We hope with some of the studies that are ongoing that they'll better disentangle that association.
Great. And for the audience, mast cell D is?
Metabolic associated steatohepatitis or steatotic liver disease. So this is the new name for what's called fatty liver disease. It has a metabolic component to it.
Thanks for clarifying. It's one of the things I've learned from working with you over the years.
Yeah. So we don't want to like have any sort of negative connotations. They've just decided to change the naming of it because this is a metabolic originated steatosis, and steatosis means accumulation of fat.
Okay, great. Thanks for clarifying that. Another question, this is following up on what you presented on the cholestyramine and the Welchol, is whether the PFAS is being removed. If the PFAS is being removed by attaching to bile and excreted, does that mean it is coming from PFAS stored in the liver? So this is someone who's been taking cholestyramine to bring their blood levels down. So I guess wondering about the sort of bigger body burden.
Yes. Yes, I would say yes. It's drawing from the liver. And then PFAS that's in the body is being kind of, essentially extracted and probably ultimately concentrating in the liver. And it's that liver that PFAS that's getting kind of drawn to the bile. And overall, that process is kind of drawing down the total amount of PFAS that's in the body and being reflected in your serum values that are being measured.
Okay. All right. And I guess building further off of this and knowing that you're in the College of Pharmacy, there's another question from a synthetic perspective. Is there action to further optimize cholestyramine and its derivatives? And can you offer some details about the synthesis? Is this a green effort?
Yeah, so couple, and I think this can answer another question in the chat bar, which is, I don't think there's a need for so it depends if you're thinking about therapeutics versus using cholestyramine or similar molecules for other things. So from a therapeutic standpoint, cholestyramine and cholesevolem, Welchol, are FDA approved for the lowering of cholesterol and LDL. And so they're already FDA approved for that purpose. So we wouldn't really want to make new derivatives because we already have ones that we know are safe and efficacious for at least lowering LDL. And now there's evidence that cholestyramine, and we hope to produce evidence for Welchol that these will be efficacious in humans and going through, the process of a clinical trial. So for that reason, I don't think we need to generate new molecules to treat or lower PFAS. However, we can draw upon understanding the structures of those molecules to use them for other purposes. And what I would just say is there are some other they're kind of different structures, but similar idea. Cyclodextrin, for example, is being explored to be used to capture PFAS because of the way it can interact. And again, it's kind of going to bind the charges up of the PFAS. So I think people are thinking about green ways and molecules that can kind of have that binding type of effect like cholestyramine, but I don't know if we necessarily need to modify cholestyramine.
Okay, got it. Thanks for answering, I think, two questions at once. I think this maybe is a question for both of you to consider. Maybe I'll toss it to Jill first. We're talking about these ways to potentially lower people's levels of PFAS in their blood. We're kind of on the earlier edge of understanding what options there are. And personally, having talked to people in a lot of PFAS impacted communities, I know there's some interest in, finding opportunities to lower the levels of these PFAS that stay in people's blood for a long time. But maybe also some, I don't think there's general, clinically approved practices at this point yet. I know some clinicians are sort of working with patients in some limited areas. So I guess this question maybe gets at some of that. At what point do we consider widespread or targeted screening for dangerous levels of PFAS accumulation at the individual level, and what would make someone a good candidate to remove these types of interventions? Jill, do you want to take a first pass at that, or I could send it over to Angie?
So anything that is going to be used as a screening tool needs to be proven to be sensitive for detecting the disease state, and then needs to be actionable. Because if we find something that we can't do anything about, what's the point of doing the test in the first place? So, and then it has to be validated. Is it for use in general public, or is it better served for a high-risk population? So once we know that something, once we know we can test for something, we need to know who do we need to test, and then what do we do with the positive result? So I don't think we're quite at that point yet. And then once the science is there, then if we have the statistical power to show that yes, this is something that can have widespread utility, maybe it's not everybody, but maybe it's women who lived in a certain age group should benefit from screening because of the potential of breast cancer, or maybe it's anybody with this metabolic liver disease that should be screening to see if maybe they should be in cholestyramine as opposed to the statins for their lipid-lowering agents. So once we have the research that shows yes, we can test this and get uniform results, and here's what we do with those results, then I think that gives us the opportunity for more widespread testing.
Okay, thank you. Do you want to add to that, Angie?
Yeah, so I just want to say that, thankfully in our PAVER study that's been funded through the Department of Defense and the Toxic Exposure Research Program, one of the aspects of this funded work is to do exactly what Dr. Oxley is suggesting, which is to come up with an aligned methodology and guidance for testing, at least from the methodological standpoint, so that there's uniformity across clinical sites and laboratory developed tests, so that people are getting kind of the methodology is the same, so that one, if a person's blood sample is being, kind of tested throughout the country, that that there will be kind of a similar number for that person, whether it's here or somewhere else. So there has to be uniformity. Second of all, has to do with kind of differences in guidance and who gets selected. Um, by and large, I think one of the major concerns is, and being a military dependent myself, is individuals who live around any sort of military installation. We do know from other publications that individuals who are close to installations can have elevated levels of certain PFAS. And so maybe, just to think about pockets and areas of individuals who may need to have their PFAS monitored because of occupation, where they're living, military service, did they live on bases, aspects like that.
Mm-hmm. And this maybe ties into another question that came in. Opening the aperture a little wider than just PFAS, shouldn't we be including some basic environmental screening tests at all annual physical exams, like heavy metals, PFAS, phthalates, bisphenols? This would be informative, and we can learn a lot to guide future prevention. Aside from, kids getting lead testing, this is, not a part of current care. I wonder what your reaction is to that, Jill. Certainly cost would be a barrier, but to your point about testing for things and wanting to know what's actionable about the results, what's your reaction to that question?
Right, I kind of have the same answer. Kind of like sequencing the whole human genome, right? Just because we can do it doesn't mean that we know what to do with that information. And so until we know the accuracy of the testing and then the impact of the testing on, does it make any therapeutic decisions in terms of screening or medical therapies? If there's nothing that we need to intervene on, we probably don't need to do widespread testing.
I would concur. I think, heavy metals, for example, there's just such a preponderance of evidence with with childhood lead exposure. There's a clear mechanism that's understood. There's a lot of rationale for that screening. And I think we just have to be careful that we don't want to unnecessarily scare people or make them take additional measures that they don't need. And so that's always the concern. What I would say is if you are concerned, there are suggestions on our Steep Superfund Center website about how to reduce PFAS and how to treat your water, what filtration you can use.
Yeah, thanks for those responses. And if I can add as well, again, having talked to a lot of people in PFAS impacted communities, one common thing that we do here is wanting to have access to PFAS blood tests to know what their levels are, to know if they've, had high exposures in recent years. They do see some value related to the medical screening, like you presented, Angie, the National Academy's guidance, which provides some recommendations for potential additional screenings for people who've had higher exposures. And it's something that they can maybe monitor over time if they have a result that's high, to follow that over time to see if exposure reduction measures are working. And that was really a strong recommendation out of the National Academy's report, was that people who likely have had high exposures and want to know should be offered blood testing. And I guess there are other chemicals that this might also be relevant for, And I know in general, we don't necessarily like through exams necessarily collect information about exposures that people might have had. But I do think that there's some opportunities there to improve clinical care down the road. And I'll share in a couple of minutes right at the end. We do have some resources on the STEEP website about medical monitoring. And the idea of medical monitoring is for people who have had exposures, that there's some medical screenings that clinicians can consider. And just for clinicians to be aware of, if their patients have had high levels of of a certain chemical, maybe there are some diseases that they're at greater risk of. And we do have some resources on a different website as well, the PFAS Exchange, which our PFAS Reach study developed. This has information for clinicians about how to get up to speed about PFAS. It has information about PFAS blood testing, and it provides resources to help provide some context to your point, Angie, of not wanting to scare people. I think with the context, to put their results into a context, that people do find that information informative when they have a sense of here's what's known, here's what's not known, and here are things I can do. I think that's also a really important element. We are coming down the home stretch here. I did want to ask, there was a question that came in specifically about your study, Angie, why the study protocol opted to use the NASM summation for eligibility criteria. Did you want to comment on that a little bit?
Yeah, so this was, yes. I mean, I think this was a pretty big debate that we had when we were trying to come up with our study design. And we felt as though that this was, at the time, the guidance that was the most rationally put forward, that we could kind of, it was a number that we could justify or use as a cutoff to have people undergo an intervention. I am not quite sure. I don't know about the greater than 55 nanograms per mil. We used the sum of 20 because that was what the guidance, basically the guidance that I showed. I don't know if I think I'm answering the question properly.
Okay. Yeah, and
I mean,
we'll have our contact information if people want to learn more about this study.
So what I would say too is this: when we looked at the Danish study, they used much lower serum levels. Actually, you have to have enough PFAS to lower. You have to also have enough. You need to think about how many patients you can feasibly enroll and have an intervention. And we felt as though 20, based on kind of the data that we had in hand, was about where we felt was reasonable from a medical standpoint to allow for an intervention, and be able to feasibly recruit enough patients to be able to test colesevelam. The use of colesevelam was useful because it allows us to be able to use it in adolescents as an anti-diabetes effect, which we felt was beneficial. And in an elderly population, you are more likely to be able to kind of manage it around medication and cut the dose. That was our reasoning.
Okay. Thank you for that. And we'll end with a question for Dr. Oxley. So this says, would it be rational to argue that the incidence of breast cancer deaths in marginalized communities is correlated to access to clean drinking water, dangerous work conditions, or other exposures to PFAS?
It's certainly possible. Contaminated drinking water is likely one of the environmental factors that we haven't fully elucidated. But we know that women in inner city communities are disproportionately affected with breast cancer. Some of the thoughts have been, is it psychosocial? Are they under a lot of stress with housing insecurity and food insecurity? But then the biology goes beyond where women live, and Black women are disproportionately affected with breast cancer. And there's differences in breast cancer between Black women from Eastern African descent versus Black women from Western African descent, and women who have been born in generations in the U.S. versus immigrants. So it certainly isn't helping, but I don't know how much of a percentage of breast cancer to blame on contaminated drinking water.
That that is a good question and something that we at Silent Spring and in partnership with MVCC and the STEEP team are all, hopefully can work on and get some more answers in the future. I would love to keep the conversation going, but we are coming up on the hour here. So I'm going to thank Angie and Jill for your great presentations and all the information that you shared. I really appreciate the audience sharing great questions. I'm sorry we couldn't answer everyone's. I wanted to share a couple of resources here, as I mentioned. So the STEEP team has come up with a medical monitoring guidance document, which you can find on our website. And this is a link to the PFAS exchange with resources about specifically for clinicians, but also for PFAS impacted communities, for firefighters, and for water and wastewater utilities. We have information about blood tests. I saw a question about blood testing that came in. Those tests currently run about $300 per test. And currently New Hampshire is the only state that's requiring, or maybe Maine is the second state. Very few states are requiring insurers to cover the cost of testing. So that can be a challenge and a barrier. I hope that all of you enjoyed today's webinar. We would very much appreciate your evaluation and your feedback. We have a survey here. There'll be a link in the chat, and we'll also send a follow-up email that has that survey. This will help us as we plan for future webinars. We already have some great suggestions for future topics. If you've missed any of our past webinars, you can find them on the STEEP website, and stay tuned. We do plan to continue this series in the spring. So thank you for attending and enjoy the rest of your day.